Yeah, so I get a lot of questions on surgical approaches to the hip replacement. So first, I would just say when we as surgeons think about the hip is very much like your house. You can have a front door and a back door, and you can use whichever door you feel most comfortable with. I think there's been a lot of marketing hype about the anterior approach being less invasive and more rapid recovery, which when we critically look at the scientific data available to us at date, does not hold water. So what do we have? Well, there was a study in the Journal of Arthroplasty by a group of surgeons, one of them being Leopold, that looked at about 29 patients in each arm, and they had 29 that had their hip done anteriorly, direct anterior, and they had 29 done through a mini-posterior. In theirs, they found that the anterior patients had a little bit better time getting up and down the stairs, but by 6 weeks, basically everybody was the same. There's a really nice study out of the Mayo Clinic. So Mark Pagnano was the senior author on this. It was in the Clinicals of Orthopedics and Related Research. They had a much bigger cohort. So they had roughly, I think, 96 patients that had posterior approach hips, 127 that had anterior or direct anterior approach hips. They standardized everything. So they standardized the restrictions the patients were put on, the pain management, the rehabilitation protocol, everything was standardized. And kind of what they found is that the DA hips had a longer operating room time, the direct anterior hips had a longer operating room time, but after surgery, they were basically the same. The posterior approach ones actually were off the cane a little faster and walking unassisted a little bit better than the direct anteriors. But basically, again, at 6 weeks, everything's the same. There's been some meta-analysis studies. So a meta-analysis is a study where they take several studies of good quality and they pool the data and then recalculate it, showing that the direct anterior has a longer operative time and greater blood loss. That's probably one thing we can say for sure. But as far as a benefit, direct benefit to the patients, both short and long term, it's minimal at best. I don't think that direct anterior is a bad approach, but I certainly don't think it's better than a mini-posterior approach. I believe how you make that decision is based on the surgeon, the patient, expectations. For me, I feel like it's hard to do better than a mini-posterior approach in my hands. The length of stay is short. My return to work is short, as short as I think it should be. I don't have any issues with pain control. I don't have any restrictions really on my patients typically after surgery, other than a couple guidelines on how to twist or turn in a specific way until the soft tissues had a chance to heal. So I don't see an advantage in my practice to a direct anterior approach, and when I personally look at the data, I'm still concerned about where the complication rate is at as surgeons learn to do it and even after they've learned to do it.